Audio. Audio Jungle. Audio Jungle. Audio Jungle.
Let me clarify more.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف خلق الله أجمعين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Today inshallah we are going to discuss one of the commonest scenarios or cases that appear in basis exam. Lower limbs examinations. Before I proceed further in my case, what I need from you to pass this basis exam, what I need from you to focus in the skills and to know from where the examiners they are giving you your marks. Based on these skills, they will assess you whether you are satisfied, borderline, or unsatisfied. That is why don't think about the diagnosis. Think about the skills. No examiners is going to ask you what is the diagnosis per se. As soon as you finish your examination technique, you will take 4 marks for examination technique. Then after that, 4 marks for welfare. As soon as you give your face to the examiners, they will ask you 3 questions. What is your finding? What is your differential diagnosis for this finding? And what is the plan of benefits? Examiners are asking you this examination skills, technique. Number 2, welfare. Number 3 is finding. Number 4, differential diagnosis of this finding. Number 5 is plan of management. Each one of these skills equal 4 marks. The total marks is 20. Now I'm going to talk about lower limbs, one of the cases that come in the CNS lower limbs examinations. Hello, good morning. Hello. My name is Dr. Adam. I would like to examine you. During my examination, if you feel any pain or discomfort, let me know. Take 2 steps away. Then after that, you will come to do general observation first for around the patient, then observation inside the patient for WASFA. W for wasting, S for any scar, F for fasciculation, A for any abnormalities, like as you see here there is abnormal clawing of the toes and there is high arched foot in keeping with this case. The first step is inspection for WASFA. Wasting, WASFA, wasting, scar, fasciculations, and any abnormal shape. Then I will come to the tone power reflexes coordination sensation. The sequence of examination technique in lower limbs and upper limbs is tone power reflexes coordination sensation. Tone around the hip, tone around the knee, tone around the ankle. Tone around the hip. Do you have any pain? No. I will start like this. This is around the hip. Then here also. I will come tone around the knee. Tone around the knee 3. Number 1, flexion, extension. Then here also, flexion, yes, and extension. Then rolling like this. Here also like this. I will do rolling while my eyes is looking to the food. If the food is moving like this is hypotonia. If it is moved as one unit, this is hypertonia. Flexion extensions, rolling and lifting. See? And this is the most important test to identify and to say 100% this lady, she has got hypotonia. If this lady is hypertonia, I will lift the limbs like this, it will move as one unit. See, this is the hypotonia. Then I will come to the tone around the ankle by movement of the ankle like this only. Then I finish, tone around the hip, tone around the knee 3, flexion extension, rolling and lifting, then around the ankle by this movement. Then I will come tone power reflexes. Power. Can you raise your both legs up please? ارفع رجولي الاثنين فوق معلش. الثانية برضه. To check for power against the movement against gravity. Then I will come to check against resistance. Up and down, out and in. This is around the hip. Around the knee, flexion, extension, around the ankle, in, up, down, out and in. Let us take it. Yalla, lefo, up, against me. Yes. Up. Up, yes. Then down, yes. Then out, then in. Then I will come to the knees. The knee like this. Yalla, in, out. Then I will come here also. In, then out. Then I will come here. Up, left hook. You cannot do it. Oh, down. Okay, here. Up, then here down. She cannot do. Out, in. Okay, in, out. She cannot do. That means this lady, she has got a weakness. The shape of this weakness, distally more weaker than proximally. Abductor more weaker than adductor. Out, level very weak. In, abductor is more weaker than abductor. Distally more weaker than proximally. This is both upper and lower motor neuron lesion signs. They are sharing this points. Distally more weaker than proximally. Abductor more weaker than adductor. Both of them are same in these points. The difference is where in patients with upper motor neuron lesions, the flexors are more weaker than extensors. I mean that the patients of upper motor neuron lesion, he cannot move his thighs up. Any person, if you say to him up, he cannot move his thighs up. This is upper motor neuron lesion shape weakness, what we call in medicine pyramidal shape weakness. While if the patient having lower motor neuron lesions like this lady, the extensors are more weaker than the flexors. That means if you ask him to push his thighs down, lower, he cannot push his thighs lower. Up, stronger. Down, very weak. You will come here also, you will get the extensor. Out, very weak. In, stronger. Any patients with lower motor neuron lesions, he cannot extend his size or his extension of his legs. Extensions of his legs. I mean that extensors are more weaker than the flexor. Prominently, you will get it around the knee. prominently around the knee. Any persons, if you meet any person, he cannot push his thigh up, out like this, extensor, out, very weak, in. This is lower motor neuron lesion shape weakness, in which there is distally more weaker than proximally, abductor is more weaker than adductor, and extensors are more weaker than the flexors, mainly around the knee. Tone power reflexes. Then I will come to the reflexes. I will start 3 reflexes. Number 1, knee, ankle. Number 2, plantar reflex. Number 3, clonus. I will come to the knee reflex. To expose. Expose the muscles first, then expose the tendon here. Then I will lift, and I will percuss like this. You have to take the hammer like this. Clench your teeth, please, like this. Yes. If you got patient having hyperreflexia or reflexia, ask him to clench his teeth. Yes. Again, same. Then I will come to around the ankle. I have to flex the knee like this, then gentle extension like this, then I will take my hand like this, then I will move. Clench your teeth. Here also I will do like that, flexion, gentle external rotation like this, then I will bring my hand like this. Clench your teeth, yes. Then I finishing the hammer, I will come to the upgoing plantar reflex. Excuse me, I would like to move this sharp object on the heel of your foot. It might be a little bit discomfort. Then, if you did not take permission from this lady, and you did plantar reflex, and this lady, she said, forget that you will pass this exam easy. Take permission from the patient first. Excuse me, can I move it? Yes. Then the movement from out and towards the medial aspect of the foot, like this. Here also like this. And here, link your heart and concentrate and focus in the big 2. Because the cause of the death inside this exam is findings. Most of the people died in this basis because of finding. If you miss this big 2 upgoing or mute or downgoing, the examiner, as soon as you finish your exam, they will ask you, present your finding. If you link your heart to the steps, I will do this, then this, see, it is mute, plantar. You are thinking about the next step. Tendon reflexes. Examiner, when he asks you, present your finding, you will not present this mute plantar. Why? Because at the time that you got this mute plantar, your brain is linked with something else called the steps of examinations. That is why train yourself on steps of examinations. When you come to the exam, you will come making your brain free only to pick up the finding. You will not be busy with technique of examinations. You will be busy only for picking up the findings, and you will do the technique of examination subconsciously, automatically, without thinking about the next step. Your heart will be only linked for or linking to the finding. Let me now turn power reflexes. I finish the hammer reflex, the knee and ankle reflex, plantar reflex. I will come to the clonus. 1, 2, 3. Then here also 1, 2, 3. I finish my reflexes, turn power reflexes, coordination sensations. I will come to the coordinations. Can you move the heel of this foot on the shin of the other leg, please. حركي رجلي تعالى دي. While your eyes is opening. وانت عينك مفتحة. Then do it while your eyes is closed. Yes. Again here. When your eyes is opening. Okay, very good. Okay, close your eyes. 1 minute. Close your eyes. Yes. If you notice, this lady, finish. She can do these coordinations while her eyes is opening. But if she close her eyes to the coordinations, can you move the heel of this foot on the leg of this, on the shin of the heel of this foot on the shin of this leg, please? Move it. حركيها وانت مفتحة while your eyes is opening. Then now close your eyes. غمض عينك. سويها وانت مغمضة عينك. This lady, the coordination cannot be done while her eyes is closed or impaired while her eyes is closed and it is intact while her eyes is opening, indicating that this lady, she has got sensory ataxia. If the person, he can do these coordinations normally, he can move the heel of the foot like this normally while his eyes opening. This is mean that is good, no problem. If she cannot do it while her eyes is closed, this is sensory ataxia. That means the joint position is lost. But if she cannot do it while her eyes is opening like this, this is called cerebellar ataxia. Again, if her eyes is opening and she crossing her foot like this, her feet like this, this is cerebellar ataxia. If she close her eyes and she cross her feet together, this is sensory ataxia. That means the joint position is impaired. Let me now continue. Done power reflexes, coordination, sensations. Sensation, I will start by, before I go to the sensation, any sensations lost below the anterior superior iliac spine and down, this is peripheral neuropathy. And any sensation exceeding the anterior superior iliac spine, that means the problem in the spinal cord, most likely this is sensory living. That is why I will start by the light touch. I'm going to touch you here, an example. Yes. Yes. I'm going to close your eyes. I'm going to feel you by this cotton piece. If you feel it, let me know. As soon as you feel it, let me know. إذا حسيتيه كلمني. Here also. Yes. Like the above, the yellow fog. Not like the above. Okay. I'm going to move up. As soon as it become like that in your face, let me know. Here they like the above. Yes. Okay. Again here. Okay, thank you. Then I will come to the pinprick. Do you feel this? Yes. Again here also. Pinprick, it is better to press here in the clavicle, while the cotton in the face. No more. Then here again. Do you feel it? Do you feel Hassan? Like the above, the before? When it become like the above, let me know. Okay, thank you. Both of them are looking same. الاثنين زي بعض. كلهن زي بعض. كلهن. Thank you. Then I will come to the vibrations. Okay. I'm going to feel you. As soon as you feel it, let me know. Okay? حساها؟ زي you feel it? حساها؟
نعم.
زي اللي فوق؟
أقل.
Okay. I'm going to if it is stop, let me. I'm going to move up. Okay? When it become like the above, let me know. Huh? They like the above. Okay. If she stop, let me know. وقفت?
نعم.
Okay. Here also. base of the big toe, medial malleolus. Here also. لما تحسي اللي فوق كلميني.
طيب ننزل فوق.
وقفت؟
نعم.
Yes. Then I will come to the joint positions. See, this is up and this is down.
هنا فوق.
This is okay here. Okay, okay, thank you. This lady, on examination of this lady, she has got in the both lower limbs, she has got a signs of lower motor neuron lesions, and the coordinations is intact with eye opening, lost when she closes her eyes. At the same time, she has got loss of all modalities of sensations up to the knees. Later, I will come to the presentations. Any CNS, all the CNS cases, whether upper limbs or lower limbs, all the CNS cases, whether upper limbs or lower limbs, divided into 3 stations. Station 1, Station 2, Station 3. Number 1, in the first station, second and third. What you will do, the first station signs, after the presentation, all the cases of CNS divided into 3 stations, with exception of cerebellar presentations. Cerebellar affection presentation, Parkinsonism, cranial nerves, and this is need a specific presentation. But here, either lower limbs or either upper limbs examinations. If you go to any exam, Irish, basis, any exam, and you examine the upper limb or lower limbs, your presentation will be dependent on 3 stations. First stations is signs of lower motor neuron lesion or upper motor neuron lesion or mixed. Then apart from that, the coordination. Apart from that, the sensation. I will come to clarify more. You will not come to these stations unless you present your inspecting finding first. And when you present your inspecting finding, it is better to use has. Excuse me. On examination of this lady, I will start first by has. Has for inspecting finding. On examination of this lady, she has. If there is walking aid beside him, this is good impressions. Will give the examiner good impression about it. If she has walking aid beside her, mention it. She has walking aid. She has got wasting in both lower limbs, mainly distally. Stop in the lower third of the thighs. She has got clawing of the toes, as you see. She has got bilateral bis cavus, and she has got a scar above the left medial malleolus. In the both lower limbs, after I finish in the has, I will come to the 3 stations. In the both lower limbs bilaterally, this lady, she has got a signs of lower motor neuron lesions in the form of wasting, double H hypotonia, hyporeflexia, mute plantar, and weakness. The shape of this weakness is mainly distally more weaker than proximally. Abductor is more weaker than adductor. And extensors are more weaker than the flexors, mainly around the knee. Apart from that, coordination is intact with eye opening, lost when she closes her eyes. Apart from that, there is loss of all modalities of sensations for light touch, bimbering, joint position, and vibrations up to the knees. My summary for this lady, she has got a feature consistent with bilateral symmetrical peripheral sensory motor neuropathy for differential diagnosis. I would like to complete my neurological examinations by examining the upper limbs, cranial nerve, cerebellum, back, and the gait of the patients. Again, any CNS, don't say you want to pass. This is the presentation. Any CNS, whether upper or lower limbs. 3 steps. 1, 2, 3 by 1. With exceptions of cerebellum, cranial nerves. Cranial nerves usually, this patient has evidence of based on. This is a presentation of cranial nerve. Forget about it. Let me come back to this lower limbs. 3 steps. If you miss these steps, your presentation will not be nicely. Imagine that this is upper motor neuron. A patient has spastic barbaris or having anything. Spastic barbaris as example for any reason, complete core transection. Also say, on examination of this gentleman has signs of, in the both lower limbs bilaterally, I will localize the area so as to take my risk. In the both lower limbs bilaterally, there is, as example, complete core transection, spastic barbaris. I will say, wallahi, this gentleman in the both lower limbs, there is signs of upper motor neuron lesion in the form of double H, double B, hypertonia, hyperreflexia, pyramidal shape weakness, and positive upgoing, positive Babinski signs with ankle clones. Apart from that, coordination cannot be assessed because of the weakness. Apart from that, there is loss of all sensation, modality of sensation up to the to the xyphisternum as examples. My summary is spastic barbaris with complete core transection. Now, in the lower limbs, in all lower limbs, you can get 3 possibilities. Either pure lower motor neuron signs like this lady, or pure upper motor neuron lesions, or mixed like Friedreich's ataxia, vitamin B subacute combined degenerations, and on examination of this gentleman has in the both lower limbs there is signs of upper motor in the form of, and signs of lower motor in the form of. Apart from that, coordination is impaired or intact. Apart from that, there is sensory loss up to this area. That is why, to summarize to you, on examination of this lady now, I will present like that. Has and in the. On examination of this lady, she has walking aid beside her. She has wasting in both lower limbs bilaterally. She has got clawing of the toes. She bilateral, she has got high arched foot, biscaphus bilaterally. She has got a scar above the left medial malleus. In the both lower limbs bilaterally, I localize the place. I will take my risk. In the both lower limbs bilaterally, this lady, she has got a signs of lower motor neuron lesion in the form of hypotonia, hyporeflexia, mute plantar, and hypotonia, hyporeflexia, and wasting. She has got signs of lower motor neuron lesion in the form of wasting, hypotonia, hyporeflexia, mute plantar, and weakness. The shape of this weakness is distally more weaker than proximally. Extensors are more weaker than the flexors, and abductor is more weaker than adductor. Apart from that, coordination is intact with eye opening, lost when she closed her eyes. Apart from that, there is stocking distribution of sensory loss for all modalities of sensation up to the knees. My summary: this lady, she has got bilateral symmetrical peripheral sensory motor neuropathy for differential diagnosis. I would like to complete my neurological examination by examining the upper limbs, cranial nerve, cerebellum, back, and gait. Examiner, he will ask you, you did good clinical examination technique, you took 4 marks. welfare 4 marks. I put in my pocket 8 marks. I didn't open my mouth. Then as soon as I finish my examination, I will give my face to the examiners. I will say to the examiners, I know that you are going to ask me FDB, finding, differential diagnosis of this finding and plan of management. Any question other than these 3 is extra mark questions. What is your finding? I mentioned it. Differential diagnosis of this finding. What is this differential diagnosis of peripheral sensorimotor neuropathy in this lady? In view of biscaphus, clawing of the tooth, and the shape of the wasting, top of my differential diagnosis is hereditary sensorimotor neuropathy, what we call Charcot-Marie-Tooth disease. What else? I will say to him could be diabetes, alcohol, vasculitis, vitamin B12 deficiency, uremia, or even hypothyroidism or drugs. Examiner, he will ask me what is the plan of management for this lady. Apart from basic investigations, I will do for her nerve conduction study, EMG, and genetic test. Nerve conduction study, EMG, and genetic test. Examiners, and I will do for her fasting blood sugar, hemoglobin A1C, checking the RFT for uremia, and vitamin B12 for vitamin B12 deficiency, or autoimmune screen for vasculitis. Examiner, he will ask you what is the benefits of nerve conduction study in patients with Charcot-Marie-Tooth disease other than to confirm the peripheral sensory neuropathy. Here is to identify the type of sensory motor neuropathy, to identify the type of hereditary sensory motor neuropathy, because they are different types. Type 1 and type 3 are demyelinating disease. Type 2 is axonal, axonal peripheral neuropathy. That is why examiner here, he will ask you what is the treatments of any patient in the CNS. If the examiners in the CNS, all the cases, if the examiner asks you what is the treatment is multidisciplinary team treatment in the form of physiotherapist, occupational therapist, specialized staff nurse, social worker, and neurologist. Physiotherapist, occupational therapist, social worker, specialized staff nurse, and neurologist. Then 2 treatment. Treatment of the underlying cause and treatment of the complications. Treatment of the underlying cause and treatment of the complications. As I said to you that regarding the Charcot-Marie-Tooth disease, if you focus with me, glowing of the tooth and this clear biscaphus, and there is, if you focus with me, the shape of the wasting is going like this. Stop in the lower third of the thighs. Very common scenario, very common case in the basis and Irish exam. That is why then if he asked you, give me another what test you would like to do, I need to do for this lady to check her gait, to look for high stable gait and to do positive. Give me one test, Romberg test. Romberg test. If this lady, she stand like this and close her eyes, she will fall down because of loss of joint positions. See you inshallah another session. Goodbye.